right. All right. So again, my name is George Minawata. Thank you all for attending and being part of the MAVEN Project. I especially want to thank our friends at La Clínica de la Raza, serving the communities of the East Bay in the San Francisco Bay Area, for hosting today's session titled Fibromyalgia with our speaker, Dr. Jay Fiechtner. Dr. Fiechtner has been practicing rheumatology for nearly 40 years, working in a large multi-specialty clinic as a hospital employee and as an owner of a single specialty private practice. He served in the U.S. Navy during the Vietnam War era, and he's been affiliated with university teaching programs since then as a teacher, professor, mentor to students, residents, and fellows. He and his wife, Carlene, live in Okemos, Michigan, and have children and grandchildren in Boston and Western Michigan. And with that, Dr. Fiechtner, I turn the mic over to you, and I'm going to turn off my camera.
Okay. Thanks, George. So we're going to talk about fibromyalgia today. I know everybody's excited. Let's go to the first slide. So our goals for today are to recognize patients with fibromyalgia, both by history and physical exam. We'll discuss history and epidemiology of fibromyalgia. We will obtain to note predisposing factors and concomitant diseases that can occur with fibro, and we'll discuss pathophysiology and treatment. I put the bottom line of do not fear the fibro because for some doctors, the term fibromyalgia does strike fear in their hearts, especially rheumatologists. Anyway, next slide. So how did we come up with the diagnosis of fibromyalgia? Well, it was a long, drawn-out process, and I'll show you later on the history of this this diagnosis. Let's go back. Okay, so the latest criteria as of 2016 are widespread muscle pain present for at least 3 months, which makes it a chronic condition. There has to be pain in 4 of the 5 body regions identified in the upper and lower body. A pain index on a 10-point scale must be at least 6 to 7. And the symptom severity has to be greater than 5 out of 10. Remember that it can be diagnosed in the presence of other illnesses. Just because you have rheumatoid arthritis, for example, doesn't mean you can't also have fibromyalgia. Next slide. So what are the body regions? We're talking about left upper region, including the shoulder, arm, or jaw. Right upper region, shoulder, arm, or jaw. Left lower region, including the hip, buttock, or leg. Right lower region, including hip, buttock, or leg. And the axial region, which includes the neck, back, chest, or abdomen. Next slide. So how common is fibromyalgia? It is probably the most common chronic widespread pain condition in the United States. Approximately 2 to 5% of the population have been determined to have or meet the diagnosis criteria for fibromyalgia. Next slide. So this is the history that I mentioned before. So doctors, healthcare providers have always recognized that there are certain people that fit into or don't fit into the neat categories that we would like them to fit into. But back in the 1880s, there were observations in the medical literature suggesting widespread pain in certain individuals. It was often thought to be a mental disorder at the time. Early 1900s, the term fibrositis was introduced. This may have been confused by the diagnosis of polymyositis, and the inflammation part of it does not really exist. There have been biopsy studies done with fibromyalgia patients, and really the only thing you can see by looking at it under the microscope is the possible increased number of mitochondria in the tissue. Otherwise, the tissue is pretty much normal. As we went long back up into the 1980s or so, which is when I started practicing, we started to recognize that there were patients that just did not fit into certain categories, especially in rheumatology. I can say that my training at the University of Washington, I did not make that diagnosis one time. But when I started in practice, I realized that we were missing a category of patients without being able to give them an appropriate diagnosis. I wasn't the only rheumatologist who recognized that, and a group of us got together and decided to have the American College of Rheumatology put together a committee to come up with a specific way of diagnosing fibromyalgia. We also got rid of the term fibrositis, again, because it does not involve inflammation. So anyway, the criteria that we came up with was published in 1990. And you may be familiar with this. This is when we came up with 18 tender points. Those tender points pretty much correlate with chi points of acupuncture. And it's not a surprise, I don't think, that is true. But the way we did the study, I would examine a patient, and I would, by my own estimation that the patient had fibromyalgia, I would send the patient to an independent evaluator who used what was called a dolorimeter to measure pain. She would produce 4 kilograms per square centimeter of pressure on these tender points. We also had some sham tender points in that study. And then the next patient I would see that was willing with a diagnosis other than what I thought was fibromyalgia, I would send them to her also, and she would do the same evaluation. Well, this happened all over the country in probably 30 different centers. And finally, we came up with statistical analysis, and the 11 of 18 tender points necessary to make a diagnosis of fibromyalgia. That and the association of what we call widespread pain. Widespread pain was above and below the waist. So since that time, there have been the 2 iterations of diagnostic criteria, and I showed you the last one that was in 2016. Once we came up with a way to evaluate who had fibromyalgia, that's when drug companies were able to come up with studies so they could look at whether or not their drug would possibly help decrease the signs and symptoms of fibromyalgia. And it did take a while, but the first drug that was finally approved in 2007, which is pregabalin or Lyrica, finally occurred. Since that time, there have only been 3 other medications approved by the FDA, although many medications are used for these patients with benefit. Next slide, please. So what are the risk factors? Is there a genetic predisposition, or is it a behavioral? There's no doubt that there are patients in the same family that have fibromyalgia. Now, again, is that genetically linked? We have no evidence of that, and it certainly can be behavioral. Environmental factors do include physical and emotional trauma, previous infections, and most recently, the long COVID patients very often have fibromyalgia. Concomitant illnesses can lead to fibromyalgia. The autoimmune diseases, rheumatoid arthritis, lupus, patients will also have fibro frequently. Hypothyroidism often will present itself with fibromyalgia. And as a result of that, there are certain lab tests that we do suggest you do when you have a fibromyalgia patient. It is very common to have other symptoms and other syndromes or disorders associated with fibromyalgia. Irritable bowel syndrome is a classic one. These patients very often have sleep disorders. They may have cognitive dysfunction. They might have mood disorders, although the studies have shown that these patients with fibromyalgia do not necessarily have any more likelihood of having serious depression than other individuals, especially those with chronic pain. I've often told my patients, if you have this much pain, it's no wonder that you're depressed. So I think that goes along with the chronic pain syndrome. Next slide. So what are some of the diagnoses you need to think about other than fibromyalgia in patients who present this way? Polymyalgia rheumatica, especially in older individuals, is important to make not to miss. Let's put it that way. One of the differences is that with polymyalgia rheumatica, the onset is usually very rapid, and patients can hardly get out of bed because they have so much pain. It's mostly in the neck and the upper back region, and sometimes it's associated with headaches and jaw pain, in which case you need to consider the possibility of giant cell arteritis. What helps you here is laboratory testing. Patients with polymyalgia rheumatica will have a high sedimentation rate, high CRP, and if you give them a low dose of steroid, within a day or two, they're significantly better. Fibromyalgia patients, steroids don't seem to help much, or if at all. Rheumatoid arthritis, RA patients will have characteristic swelling of joints, morning stiffness, which is much more pronounced than you might see with fibromyalgia patients. And again, they will have positive laboratory tests, including rheumatoid factor, CCP, et cetera, et cetera. Lupus, similar situation. They will have the symptoms and signs of lupus, including skin rash, et cetera. But they can also have fibromyalgia at the same time. Polymyositis, I mentioned before, this is actual inflammation of the muscle proved by biopsy. These patients usually have much more weakness than pain, and they will simply be unable to go up steps. So mostly upper arms, upper legs are involved with polymyositis. Osteoarthritis, which is something we all get if we live long enough, certainly osteoarthritis will have fibromyalgia at times. Nerve impingement syndromes are important to differentiate as well, and certainly you'll see more of a localizing type of pain into the legs, for example, in case of patients with low back nerve impingements. Next slide, please. So how do we evaluate these patients? Well, usually we have a patient questionnaire before the patient ever comes in to see you. And frequently, a patient with fibromyalgia will have a lot of answers checked positively, and even with notes scribbled on the sides of the papers. So that might be a tip-off. A pain scale diagram should always be included. The patient will frequently say that they have pain all over, in quotes. As I mentioned before, there may be a family history. Another important history to ask about is physical or mental abuse, or also just trauma, having been in an automobile accident, for example. Multiple symptom complaints are frequently present, and you have to often realize that this patient has seen many other caregivers in the past, may have had multiple tests, multiple x-rays, and scans, et cetera, et cetera. When you do your examination, the one thing that'll always stand out is the fact that these patients have multiple tender areas in their muscles. And as I mentioned before, in the upper and the lower extremities, as well as in the trunk region. Next slide. I think that's the same one. Yeah. Can you get to the next slide? I still haven't got there. There we go. So this pain scale you've seen before, 0 to 10. I mentioned we need numbers 6 to 7 before we will classify them in with fibromyalgia. Next slide. So what about management of these individuals? Sometimes this can be daunting, and it does take a lot of effort. That's why many physicians are loath to take care of these patients. But given the right direction, patients can do very, very well. So it's very important to involve the patient's family as well, because there's often a great deal of misunderstanding as to what fibromyalgia is, and difficult for the family to understand. It's often difficult for the family to adjust to some of the things that the patient can't do that they used to be able to do quite easily. Again, I mentioned the need to make sure that if they do have other diagnoses with the fibromyalgia, that you deal with those. So you want to check out a few things: thyroid disease, lupus, rheumatoid arthritis, polymyalgia rheumatica, as I had mentioned before. As far as treatment is concerned, physical therapy is very, very useful. Exercise is critical. So you have to get a patient on a graduated exercise program. You start at a very low level of exercise, because people who are in pain are pretty reluctant to do a lot of strenuous exercise. So they need to start at a very low level and gradually work their way up. Water exercise is a very, very good way of getting people started with an exercise program. Behavior modification techniques are quite useful. Cognitive behavioral therapy has been shown to be effective in treatment for fibromyalgia. Fibromyalgia support groups are also very helpful for people to see that there are others in this similar situation, and especially people who are there who have been doing better, and to give them some sense of hope that they will feel better. As far as medications are concerned, I mentioned that there are not a lot of FDA-approved medications specifically for fibromyalgia, but certainly there are medications that help. Simple analgesics, including oral and topical NSAIDs. A lot of patients really do respond well to the topical NSAIDs, which are now available over the counter. And also, you can certainly, if you can find a compounding pharmacist, I often use, instead of a 1% diclofenac ointment, I will use 5%. And studies that we have done in our clinic and also around the country have indicated that the toxicity of these topical analgesics is very minimal. As far as using oral NSAIDs, I like the longer acting ones, especially as patients start an exercise program. They will often stop their exercise program because of the way they feel the day after or 2 days after they start exercising. And I think NSAIDs do help with the stiffness and soreness that those patients experience, and hopefully allows better compliance as a result. The SNRIs are approved. 2 of them are approved uh, and can be used. The problem with SNRIs, and I'm talking about duloxetine and also sorry, it's no, the other. I'm sorry, I have a lapse of what the other one is. But anyway, the problem with these is if you start out at a high dose, the patients frequently will have nausea and difficulty tolerating it. So I will always start with an extremely low dose and very gradually taper them up. Milnacipran is the other SNRI, and they are helpful. Tricyclics are used. They are not specifically approved, but and tricyclics include the medicines such as Flexeril, which if used in a low dose and taken at least an hour or 2 before you go to bed or they go to bed, it will improve the quality of their sleep. Other medication that have been improved, I mentioned pregabalin as being the first FDA-approved drug, work in a different way. They are neurotransmitter modulating medications, but they are helpful. Again, you want to start with a low dose and very gradually increase the dose if necessary. Fibro patients do generally very well with low doses and do tend to have more side effects than you would hope they would have at a higher dose of these medicines. It's important to have follow-up probably within 2 to 3 weeks to make certain that the patient is comfortable with the diagnosis, and also to make sure that the patient is starting to take responsibility for themselves in getting better and not being simply dependent on you or depending on others like the physical therapists or massage therapists. They need to start showing improvement on their own, and they need to take responsibility for this. Next slide. So what other specialty care might be necessary that you might want to consider referring to? Rheumatology, especially if there's a concomitant autoimmune disorder. Physical medicine and rehab or physiatry, if any physical deformity is involved, which is contributing to the diagnosis. Osteopathic manipulation, I've found to be helpful for a lot of patients. They can unfortunately become dependent on the manipulation, and this as well as other important. Could we go back? I guess we flip back to the last slide again. Oh, now we're going way back. There we go. Patients can be dependent on certain things like massage therapy, and if they don't do the other things, especially exercise, etc., in combination with that, then they usually don't make a lot of progress. So it has to be a constellation of things that you use in order to get patients going. A lot of these patients have headaches, and neurologists might be necessary for an evaluation or some type of treatment. Obviously, if you are really concerned of structural abnormalities, imaging should be done. If you do detect that there is significant mental illness involved, then certainly psychiatry is helpful. Psychology, and I find psychology, social workers, usually in the centers that are good with treating fibromyalgia patients, they'll have an individual, such as a social worker or a psychologist, working there, and that they are very, very useful. And I mentioned before the cognitive behavioral therapy, which is helpful. Next slide. So the prognosis is good, but it does take a bit of effort on the part of the patient as well as the provider to get the patient on the right track. They need to be well motivated, and usually they are. People don't want to live with chronic pain usually, and I think what you need to do is to be as supportive as you can in this regard. Exercise, I mentioned, is critical, and you have to get these people moving. Generally, patients don't need long-term medication treatment. And I mentioned the medicines before that we use. As the patient gets better, they can be tapered off and don't necessarily have to take any medication in the long run. And certainly opioids should not be used at all. Supportive approach and follow-up, as I mentioned before, it's very important for these patients to have follow-up and for you to be as supportive as possible in that regard. Fibromyalgia should not by itself be a disabling condition. Next slide. So we have a case study. Females are more frequently involved than males with fibromyalgia. This is a fairly typical patient, 28-year-old female with a 2-year history of widespread muscle pain. It started shortly after the birth of her first child. A sleep disorder is very often associated with fibromyalgia. And having a young child who tends to wake you up in the middle of the night, or having an animal sleep in the bed with you. I've mentioned that to my patients a few times. Anything that disturbs your sleep on a regular basis is not going to be very helpful. Generally, I mean, this woman did have some morning stiffness, in quotes, but it went away very quickly. Another common complaint of patients with fibromyalgia is that they notice swelling of their hands, especially, but also their feet when they get up in the morning. Now, when you evaluate patients, unless they have other concomitant illnesses, they really don't have a lot of swelling. You know, you look at them and say, you know, I don't see the swelling, but the patients do have that as a complaint, that they feel swollen. This individual had seen numerous care providers for it, including acupuncturist and herbalist, had numerous blood tests, numerous imaging studies, and they were all normal. And of course, the individual can get very frustrated after seeing that many people or many caregivers saying, I can't find anything wrong with you, in quotes. She did have a family history of chronic back pain and rheumatoid arthritis. She had a history of possible physical or sexual abuse as a child. She may have had anything similar to PTSD as a result. Next slide. Examination, as you might expect, she had multiple tender points.
Help is available.
She had multiple tender points above and
The National Sexual Assault Hotline offers free and confidential support whenever you need it.
very interesting.
Would you like me to call them for you? Let me know if there's something else you need.
Does that happen all the time when you mention sexual abuse? Interesting. Anyway, the examination showed multiple tender points, no evidence of joint synovitis that you might see with somebody with rheumatoid arthritis. Lab tests that hadn't been done before, if you do them, including TSH level, sedimentation rate, CRP, Those tests were normal. She was sent for treatment with physical therapy, as well as considered for psychological and cognitive behavioral therapy, particularly because of past history of PTSD. Aerobic exercise was started, and pool program was fortunately available, and medications were used on a temporary basis, mostly to help with sleep and post-exercise pain. Next slide. So in summary, fibromyalgia is a fairly common illness, and I'm sure you all see patients with it. Both sexes are affected, females more so. Main point of diagnosis is chronic, widespread muscle pain. And it's frequently associated with sleep disorders, irritable bowel syndrome, migraine headaches, et cetera, et cetera. You should always rule out other treatable disorders, including hypothyroidism, autoimmune diseases, et cetera. Examination will show multiple areas of muscle tenderness, and the treatment should be individualized. And again, I will emphasize that the exercise program is essential to get people better. I think, next slide, I think that's just a reference. So the ACR, American College of Rheumatology, has a lot of information about fibromyalgia, the Arthritis Foundation as well, and so does the National Fibromyalgia and Chronic Pain Association. It's nice they have brochures, most of these organizations as well. Next slide. And some of those organizations have support groups, especially the Arthritis Foundation, as far as I know, and certainly the fibromyalgia societies. So these are some of the references. The first one is the study that I took part in, the 1990 criteria for classification of fibromyalgia. And then the later criteria committees are mentioned as well after that. Next slide. And that's it. Feel free to contact me anytime about your patients in this regard or whatever else in rheumatology. And also you can contact Megan Fine in regards to anything more about this presentation, etc. If we have any if we have any questions, George, I'd be happy to answer them.
Sorry about that. Sorry about the technical issues. There was
Oh,
one
that's-
person who said they were having audio issues. I don't know if anyone else was. I didn't see it in the chat. I hope it was just the one person.
Yeah.
Okay. I see there is one question. When patients are consistent with an exercise program and medication therapy of choice, is there an average length of time you see in practice in which it takes the patient to report improvement?
Usually they improve within a month or so. You know, and if they stick with it, I anticipate that within a year the symptoms should go away completely. But you know, everybody's different in how they respond.
Mhm.
And obviously, if they also have a concomitant illness, you know, you have to deal with that as well. And if that illness is not doing well, then the fibro tends not to do so well either.
Okay. Any other questions from the audience? I've got a question on the latest criteria. There was a pain kind of score that you went over, but there's also this symptom severity also that also had a different. What's the difference between, you know, isn't a pain index kind of a symptom severity score?
Yeah, no, I know I think that when you're using you know, you're palpating the patient to see what areas are tender, then you ask them how tender? Is it a 5, 6, 10, that sort of thing. Our original criteria, we had a pain or a score of 1 to 4. And, that was, I guess they thought that was confusing in the later criteria. But so they ask him that, how much is that specific pain? The other one is just generalized pain, up to 0 to 10 score. And that's you have a pencil and paper type one.
So the pain score is really an overall score, and then the symptom severity is at the pain points, or the
Right.
trigger, so to speak.
Yeah,
Okay.
tender points. I
Okay.
know.
All right. A couple more questions have come in. Can you comment on vitamin D deficiency as contributing to fibromyalgia symptoms?
There really is no evidence for that. Obviously, if patient is vitamin D deficient, you want to correct that, but you're not going to use mega doses of vitamin D and get improvement with that.
Okay. Next question, is Lyrica the most effective drug for the condition? And if so, what's the typical starting dose that you would use?
Well, I mean, Lyrica works. Now, for a long time, Lyrica was under patent. So guess what? We use gabapentin or Neurontin. Now, the strange thing about Neurontin and gabapentin was that it was mostly used for pain, not for seizure disorders, which it actually was approved for. The company that made it, which I believe was Pfizer, was fined, I don't know how many millions of dollars because they were telling people that you could use it for pain. And we certainly did. So I tend to use gabapentin first because it's easier to titer. So you start with a lower dose and then very gradually increase with gabapentin. I'm sorry, with pregabalin, I'll use as low a dose as 25 milligrams, once a day, and then maybe gradually use it twice a day. And as I said, it's very important to use a very slow, steady increase because of the potentially side effects. And that's true, with other medications too, including the SNRIs. Savella is the trade name, and of the second one I mentioned, and Cymbalta is the trade name of the first one. That was approved for fibro.
So what kind of doses, if you're using gabapentin, are we talking doses that, at higher doses, it gets, drowsiness and sleepiness is,
yeah, I mean, I'll start again with a very low dose, 50 milligrams perhaps, and then slowly, gradually increase it. And with gabapentin, you're going to have to use maybe more doses than you would with pregabalin because pregabalin is longer, has a longer half-life.
Okay. Another question in the chat is, how often is fatigue a dominant feature, and when it appears, is it debilitating?
Yeah. I'm sorry if I should have made more of an emphasis upon it because fatigue is is very common. And again, that might be more so associated with sleep disorder patients, but yeah, fatigue is definitely one of the symptoms that patients have.
And it sounds like it can be debilitating for some patients. Is that fair to
very
say?
definitely.
Okay.
Yeah, and there's a lot of overlap between this and chronic fatigue syndrome.
Okay. And that was the next question that was in the chat.
Yeah. Right.
Okay. All right. And then you mentioned the COVID, the potential for, post-COVID.
Yes. Yeah, and
whether it's a trigger or it's part of the of long COVID.
Well, yeah. No, I mean,
elaborate more.
Right. Debilitating diseases, I think, can certainly predispose to fibromyalgia. I think that's kind of a natural, unfortunately, natural occurrence after that. That there's been a couple of interesting studies that have identified antibodies in fibromyalgia patients, which affect nerve endings in a certain way. And so there's some talk of fibro being an autoimmune disease now. That's not widely accepted, but there are some studies that suggest that. And there are some interesting other treatments that are being used, just like people with PTSD using treatments like that. I don't know any magic mushroom studies at this point, but I wouldn't doubt that some patients have tried them.
Whatever drug company just got shot down for PTSD, maybe they'll pivot. Who knows? A couple more questions. How do you differentiate between chronic fatigue and fibromyalgia?
It's difficult. In infectious disease, people might say there are some things that are different in regards to the cells and the cell distribution, et cetera, et cetera. But the symptoms are pretty much the same. I mean, not all chronic fatigue syndrome patients have muscle pain, but like I said, a lot of patients, there's definite overlap between the two. And you can call them what you want to, but you just kind of have to get them to get better and exercise, slow, gradual process of treatments. People do get better.
Is there evidence or personal attestation to benefits of using a chiropractor as part of the treatment regimen?
Well, I mentioned osteopathic manipulation. And I have to admit, I've had patients with chiropractic treatment, who have felt better. Now that's, a short-lived occurrence that yes, they feel better for a while, but unless you incorporate that with other treatments, especially exercises I keep mentioning, as well as medications, et cetera, et cetera. No, it's fine to have them do chiropractic. A couple of studies I've done in Michigan with an individual who is a chiropractor, but he also had a PhD in biomechanics, and so we did a couple of interesting studies looking at pain, et cetera, et cetera. Anything else?
There's another question in the chat. There's a condition where fibromyalgia or chronic fatigue progresses to a very severe degree to a level where it is incapacitating. Don't recall the exact name, but encephalomalacia is somewhere in the name. Am I recalling this correctly? Does that ring a bell?
Well, I don't know. It's cephalomalacia, cephalomyalgia, myalgia. I mean, that basically is myofascial pain syndrome, but yeah, I mean, some people are very debilitated by this, and they're tough patients to deal with, but you have to be as patient as the patient is.
And myofascial pain syndrome is separate, is different than fibromyalgia.
Myofascial pain syndrome is usually defined involving the neck and the upper back region. And there's similar symptoms, very tender spots, etc. Will have some of the same symptoms as fibromyalgia too. But technically, you don't call that fibromyalgia because it's not above and below the waist, not widespread.
Okay. I don't know if that answered the question.
Yeah, no, I'm not sure exactly what he's talking about.
Yeah. Any other questions from the audience? Let me just see if there's anything else in the chat. No. All right. We've got a few more minutes. Well, let me just remind everybody about the CME. Please fill out the information when you get the survey, the date, and speaker are important. If you were listening in on a different on someone else's computer watching, please put your email address into the chat so you can get CME credit. And if your clinic wants to sponsor the same talk, this was a great talk. I didn't know that fibromyalgia was the most common rheumatologic condition. Please contact Kristen Talbot at ktalbot@maven.org, whether it's this topic, another rheumatologic topic, or a topic in another specialty. Ben Mandek said, are you talking about myalgic encephalomyelitis, which I think is chronic fatigue, the other name for chronic fatigue.
Oh, okay.
Yeah. Yeah, yeah. Okay. All right. All right. With that, I think, again, Dr. Fiechtner, thanks a lot. It was a great talk, very informative. I'm not sure that I think I'm less scared of fibro. I'm not sure that I'm at ease.
Yeah. No, it's an undertaking, and what you have to go through with your patient, and you have to, the patient, you have to stick with them, and they have to stick with you, I guess. But eventually they get better. I've been very happy about the results. But as I said, some of my colleagues, if they see fibromyalgia patient coming in, they usually will leave the office.
Well, I think maybe, unfortunately, more and more of us are maybe getting comfortable that sort of situation in the post-COVID world we're kind of living in.
Yeah, no, that's a good point.
And I really appreciate that history that you gave of fibromyalgia, because, maybe we're in the early days of that with the, post-COVID, long COVID syndrome. Seems like we're still kind of thrashing around trying to figure out how to even define it.
Yeah, no, I know. That's what we struggled with fibromyalgia for a long time, back in the 70s and 80s. And it took a long time for us to get things together in order to come up with a definition so that people could identify what we were talking about, and also come up with treatments. That was very important.
Yeah, I mean, clearly made progress, and that history of medicine, history of fibromyalgia is really useful for that. Hopefully, it gives you some hope around long COVID also. It's just the timeline is, you wish you could compress it a little bit, right? For ourselves and our patients in particular who are suffering from this.
Yeah, correct.
All right. Okay, thanks again. And with that, I will stop the recording. And we're getting lots of thank yous from the crowd. So
Thank you. Thank you for
thanks
listening.
again.